Welcome everybody to today's Penn AI Tech webinar. Penn AI Tech is the Penn Artificial Intelligence and Technology Collaboratory for Healthy Aging, an initiative funded by the National Institute on Aging. We have our previous webinar speakers on our YouTube channel, and today for our webinar, we're very happy to have with us Dr. Ann Turner. Dr. Turner is a professor at the University of Washington with joint appointments in the Department of Health Systems and Population Health in the School of Public Health and in the Department of Biomedical and Health Informatics in the School of Medicine. A board-certified pediatrician, Dr. Turner is a physician and research investigator for the CDC Health Promotion Research Center at the University of Washington and the Northwest Center for Public Health Practice. Her research focuses on the use of information technology to improve public health practices and address key public health problems. Her public health informatics research ranges from the use of natural language processing and machine translation to improving access to public health materials to investigations into information management practices of older adults. I want to remind you all that you can post questions for Dr. Turner using the Q&A feature on your Zoom window. And we'll have a chance after her talk to answer some of your questions and have more of a discussion. And with that, I'll turn it over to Dr. Turner. We're so thankful to have you here with us today.
Thank you, George. It's a pleasure to be here. I'm just going to share my slides. Okay. Thank you all for being here, and thank you for the invitation to speak for this webinar series. I'm Ann Turner, and I am from the University of Washington. I'm going to talk about our research into decision-making in dementia care regarding preferences of people with memory loss. As George, thank you for the introduction. As George mentioned, I'm at the University of Washington. I'm the principal investigator for the Decision-Making in Alzheimer's Research Project, which we call DMAR. It's a National Institute on Aging, R01. And we're currently in our 4th year of the research. And as George mentioned, most of my research focuses on different public health informatics issues. Over the last 10 years, despite being a pediatrician, I have focused on the information needs of older adults and decision-making in Alzheimer's. So as background, nearly 7 million people in the US have Alzheimer's disease and related dementias. And currently, there are no curative treatments for dementia. And management of the disease involves providing supportive care and treatment of symptoms. Many people with Alzheimer's disease and related dementias receive their care at home by the 11 million unpaid caregivers that spend approximately 32 hours per week in providing care for persons with dementia. As dementia progresses and care needs increase, decisions about care needs also increase. However, persons with dementia are often left out of decisions regarding their care, especially as their disease progresses. And we lack ways to measure and track preferences of persons with dementia. The goal then of the DMAR project is to keep older adults with dementia involved in decision-making through the development of a preference elicitation tool to identify and track preferences related to transitions in care. Our approach has been really multidisciplinary. It takes a kind of a team to look at this complex issue of decision-making in dementia care. It's very person-centered regarding the decision-making. We really try to focus on the person with dementia as well as the caregiver. And we're using a technique called discrete choice experiments, which I'll describe in a few minutes. And throughout the project, we've really used user-centered design principles to help in the development of the DCE tool. This is our multidisciplinary team. We have geriatricians, dementia experts, individuals that are from the University of Washington, as well as elsewhere, that participate in our Alzheimer's disease registry. We have user-centered designers, individuals that are involved in informatics and designing tools for older adults. More recently, we've expanded our DCE to have Spanish language enrollers as well as interviews. And we have biostatisticians, database designers, rehab medicine specialists, and health economists with expertise in DCEs. The by person-centered decision-making, we mean putting, in this case, the person with dementia at the center of decisions. And that doesn't mean that necessarily the person with dementia will be the ultimate decider, but that their voice again will be heard in terms of decisions about transitions in their care. We try to understand and respect the individual needs, preferences, and background of individuals that are making those decisions, and try to keep the research centered on those issues that matter to them most. This is an example for those of you not familiar with the concept of a discrete choice tool. Another word is conjoint analysis. This is a survey technique that was developed really in terms of manufacturing and product development in order to see how people make decisions about buying a product. And, if it's a car, is it the color? Is it the model? What attribute of a given product gets weighed most importantly in decision making? And this technique's been used increasingly in healthcare to find out more about how people make decisions about their health care. It provides hypothetical scenarios where the attributes are levels change and people are asked to choose one option or the other. And through giving a series of questions with varying attributes, you uncover how people weigh different factors in making complex decisions. This type of survey, as you might imagine, can be cognitively difficult. And so a lot of what we've done over the last year or two has been trying to design a DCE tool that is simple and easy to understand for people that have memory loss. We've done this through using user-centered design principles. We've involved the users, both people with dementia, caregivers, and people that work with dementia, individuals, throughout our design process. We've really sought to have a clear understanding of the potential users, the kinds of tasks they're involved in the environment, and social backgrounds of the different folks. We've used an iterative design principles where we test with users each step of the way and evaluate the success of our development. This is the overview. This study started just as COVID isolation began. And the first aim really was to talk to individuals and find out more about what types of decisions are being made and what attributes are most important in those decisions. That was followed by aim 2, in which we would develop the DCE tool to elicit preferences about transitions in care. And now we are currently in aim 3, where we're using the DCE tool to track the consistency of preferences over time. And throughout, as I said, we've been seeking input from persons with dementia and caregivers. So I'm just going to go over these 3 aims, what some of the methods and the results. In aim 1, as I said, we conducted interviews with key stakeholders. The questions we were asking, and these were in-depth interviews over Zoom, again, because of COVID, and they generally lasted about 45 minutes. And we wanted to find out what decisions were being made related to supportive care in the context of memory loss and what factors were considered when making those decisions. We interviewed 79 individuals. 24 of them were persons with memory loss, ranging from mild to moderate. Individuals with severe memory loss really weren't able to engage in interviews, but we did get input in terms of informal caregivers of people with severe dementia. We interviewed 37 informal caregivers and 18 professionals who worked with individuals with dementia. These individuals were providers and staff, social workers, and volunteers that worked with people with dementia. And through this, this really expanded our concept of decision-making. Originally, when we wrote the grant, we were really focused on this last part of moving to more supportive care. But in talking with many people, we realized that there were decisions that were made all along the path of dementia. And the first being generally, and this is of course a synthesis, so everybody's path is slightly different, but often the first decision is in seeking a diagnosis, going to a provider. Often people have seen and suspected memory loss, but eventually seeking a diagnosis. Then other decisions include shifting everyday tasks, often within a couple or within a family, things like bill paying or family chores get shifted to the caregiver and away from the person with dementia. The decision to stop driving is a big decision, and many people talked about that decision. And then as the disease progresses further, depending on people's available resources and both financial and social and community, people would either increase their informal care. Some people would stop working so that they could take care of a loved one or bring in formal care. And often then as it progressed, either moving to a more supportive care facility or increasing care into the home. Now Jean Taylor is a research scientist on our team, and she's written a paper, and I have the publications at the end of this talk, which I'll share with you. But she described some of the qualitative themes that came out of our interviews, and that affected planning and discussions about transitions in care. And one major issue that really was challenging about these discussions is people felt that it was almost impossible to plan because you just didn't know what you were planning for. So because the trajectory is unknown, many people have never encountered individuals with dementia. So it was really hard to plan when there were so many unknowns. This was it for people that had a family history of dementia. The idea of planning ahead was more, I think it was easier, but for most people, they found it difficult to plan because they weren't sure what they were planning for. There was also a desire to really maintain life as they knew it. Here's a quote: "It looks to me like we're on a path or a road. We haven't crossed that bridge yet, so I haven't really thought about that much." So people were really, whether it's denial or we also think that cognitively it's difficult to think about the future, but also many people had decided to live their life as fully as they could at that moment in time, and thought that they would deal with the issue of transition and care when they were more severe at a later date. Unfortunately, what we know is that at that later date, people are often not in a position to make decisions. Another theme that impacted actually how we designed the DCE tool was the importance of home. We heard this over and over again, that I'm happy where I'm at. I have lots of good friends, so why would I want to move? People really wanted to stay in their own homes at all costs. And so actually this did impact our scenarios in terms of moving to a facility. And then there are obvious reality is resource constraints. That many people don't have long-term care insurance in 8 facilities that care for people with dementia are costly. And as this person said, I was anxious about the fact that there's not much available in terms of housing for seniors that's within my financial range. So the costs of care also really play a role. So from our in-depth interviews, we took several things into consideration in making the DCEs. That decisions for supportive care take on many forms. Older adults and caregivers strongly prefer to stay at home if possible. There are tensions between caregivers and persons with dementia. There's also tensions there's cultural norms, so that carry over. We take care of our own was something we heard with respect to culture. And also caregivers often, or people with dementia rarely mention caregiver burden and issues around safety. However, caregivers certainly did talk about it, as well as staff. And so there was this tension between safety and autonomy that took place between discussions with caregivers and persons with dementia. And then there was a ongoing need for resources about dementia, the course of dementia, information on how to deal with some of the changes in transitions in care, and tools for planning, which reinforced our work in terms of trying to develop a tool to help assist with planning for the future. One issue that really played out with this respect is that persons with dementia had difficulty imagining or thinking about the future, especially a future where their disease was more severe. In aim to, then we developed the DCE tool. And this is sort of the overall model of the DCE preference tools work off of. You're given a scenario and you're asked which option you would prefer, A, B, or C. C often being an opt-out option. And it's really important to pick the right attributes that you're picking. In this example, as you can see, there's 6 different attributes on the left. There's varying levels of each attribute, and then people are asked which service they would like, and then there's the opt-out neither on the right. Again, this is a cognitively difficult DCE because you have to weigh so many factors. So we really wanted to limit the number of factors to no more than 3 if possible. So that put the onus on us to really try and pick those factors that were most important. The number of factors or attributes that we came up with after our interviews and from prior studies was extensive. This is a list that we came up with, and again wanted to reduce it to 3, at most 3 factors. One of the ways we did this was using heat maps of the codes from our qualitative interviews. And I don't expect you to, I know there's a lot on this slide, but basically we use color coding to identify what attributes were mentioned most frequently by persons with dementia versus persons caregivers versus staff. And this helped us see where there were overlaps in attributes such as the degree of function and where there were differences such as in safety. We also realized in going over the interviews looking for attributes that the discussions on the part of the persons with dementia were very limited. People, as I said, did not want to talk about a time when their disease was more severe. So the details were it was much less rich narrative than had been for the caregivers. And we wondered, Annie Chen, who has worked with visualization and storytelling, we wondered that if we could use visualization techniques and storytelling techniques to get persons with dementia to talk more about future decisions. Were we able to tease out the difference in talking about past changes, current changes, and future changes? So we conducted 15 sessions. These were also done on Zoom. Again, the pandemic was still very much with us. So we used a commercial platform for developing a storyboard, and we developed sets of icons, and these were conducted solely with persons with dementia. And we would ask them to describe a past decision, a current decision, and then a future decision. And we hope that through the storytelling, we might get richer discussion about future decisions. And while theoretically it was a great idea, we really didn't find that people could that this technique of storytelling and icons, we got richer information about past decisions and current decisions, but people still really balked when it came to talking about the future. So the lessons learned from the visualization tool were that the icons really seemed useful in stimulating memory. but the discussions about the future continued to be difficult. People often said, well, this isn't going to happen, or that's not where I am. And sometimes people got frustrated and had strong feelings about talking about the future. So we realized this was going to be an issue with the DCE. And in fact, it kind of underscored the fact that the DCE really asked for less details and less narrative than the interviews we were doing. So that could be a positive. This is a pretty busy slide, but this is just to show the process of going from many attributes to selecting the 3 attributes we did for the discrete choice experiment. We the first level of attribute refinement was we formed an attribute team. We looked at the heat maps. We ranked different attributes. Then based on those rankings, we performed think alouds where we would provide different attributes and get feedback from persons with dementia as well as caregivers. We did a logit model to look at which rankings, which attributes we were ranking highest. And we used input from our visualization exercise and ultimately came up with 3 main attributes. And those, and as well as icons to go with them. So the 3 choice tool characteristics that we focused on were problems with memory and function. So the degree of having problems of memory and function, changes to support safety, and hours of paid in-home care, which is a combination of resources, financial resources, as well as caregiver burden. This is the choice tool format, and we worked with persons with dementia with different formats, with having the options horizontal or vertical to see which made it easier for people to compare. And in this format, which is a more standard DCE, where the options are vertical, did seem to work better in terms of asking questions. So people, on the left, you have the attributes, then each option has varying levels of those attributes. And option C was assisted living. And again, that what we hoped, we knew people did not generally want to go to assisted living. So the hope was by using this option C, it would bring people back to option A and B to weigh their preferences. The DCE Think Alouds helped us in simplifying our instructions that we give before the DCE. We tested visual cues, which icons represented the concepts that we were trying to get across. We started to add questions asking people where they were today in terms of the attributes, to just say, okay, this is where you are today, and what we're going to do next is talk about a future state. So we tried to just reinforce what has been and what will be in the future. And again, using the opt-out of assisted living, which did seem to work in bringing people back to choosing between option A and B. And participants, we were very relieved to see that we successfully created questions that people seemed to be able to weigh the trade-offs. And this is an example of a choice task that we have 6 questions, and they differ. One way of simplifying the questions, again, was for the first problems with memory and function, we keep that consistent over all the options. and people are asked to select option A, B, or C. So now we're into the last aim of our study, which is the longitudinal study with dyads, where we administer the DCE tool over a year period. And we just this week actually celebrated our recruiting our 100th completing DCEs with 100 dyads. Each DCE consists of a preamble where we explain how to do the DCE. We ask some questions, demographic questions. We assess people's cognitive and functional status through using the QDRS. And then they are given 6 DCE questions. And there's 2 blocks of DCE questions, and each dyad is randomized to one of those 2 blocks. And we're conducting the DCE at baseline and 6 months as well as 12 months. So we'll be able to assess any changes that take place over the year period and changes that are between the person with dementia and the caregiver. So what we try to do is we really attempted to do the DCE separately, one with the person with dementia and at another time with the person with that's the caregiver. We've asked caregiver, obviously these are on Zoom, so we want the caregiver to be available in case there's technical issues, but we've asked the caregiver not to engage in discussions about answering the questions, because we really want to hear just from the person with dementia without the influence of the caregiver. So the dyads that we're recruiting are older adults, 60 years and older, that are experiencing memory loss, and they don't have to come in with a full diagnosis of dementia, but they need to have sought up a care from a provider regarding their memory loss. And then the caregiver can be someone who cares or knows them well enough to be able to answer questions on their regarding their care. This is just a schematic of the DCE. We're doing baseline. As I said, we just completed 100. We hope to have 120 enrollees. We've also started our 6 months. We've done about 25 6-month follow-ups, and then we'll complete. We hope to complete it within another 6 months from around today, the longitudinal study. We really relied heavily. In fact, we could not have done this study without the UW Alzheimer's Disease Registry in the Memory Clinical Core at Harvard Review Medical Center. They've really, they are providing us with names of people that have signed up to participate in studies. Again, really has been critical to the success. We are aware, though, that that is a population that's not really entirely generalizable. So we've worked with community centers and senior centers to try and get additional participation. It's taken a lot of persistence, multiple calls. Many of our participants are very busy. Sometimes they forget about appointments, but we just keep trying to get people involved. An issue that we've been addressing all along is having ethnic and socioeconomic diversity, and we are continuing to work on it. As great as the registry has been, it itself is not terribly diverse, and we have currently about over 90% of our Participants are white and middle to upper class. We, in an effort to diversify our enrollment, we have been working with Alzheimer's specialist in Hawaii. One of our researchers is from Hawaii, and we've reached out and connected with the Alzheimer's Association in Hawaii. We have attended different community centers and retirement communities that serve diverse populations. And more recently, we've hired bilingually Spanish individuals to conduct interviews and translate our materials into Spanish. And this is an example of our flyer that we developed both in English and Spanish to encourage recruitment. So we've, in summary, with our user studies, it helped us to keep tasks visually simple and not overly complex. The role of the caregiver continues to be one that it's a little bit challenging, but most people understand the idea that caregivers understand the idea that we really don't want them influencing, but we would like them to help out with the technology if necessary. Our team members have become increasingly experienced in working with individuals with dementia, and we have a close association with the HPRC registry. We continue to be patient and flexible. We will do interviews in person if that works out better for people, but most people do prefer Zoom if they have the technology. And our community members and advisory board also have been critical to the success of this study so far. And this is just a list of some of the community partners that we've been working with. So I want to thank you for your attention and thank the DMAR research team, which really has been just really working hard and has led to the success we've had so far. Our study participants who've been great and community partners, as well as the National Institute on Aging, that provided the funding for this project. And if, as I said, we will be continuing to enroll dyads over this month. And I give the contact information for Jean Taylor, our research scientist. There's also the QR code if people are interested in finding out more or enrolling in the study. We would love to hear from you. And here are some publications that have come out of the work that I described today. And I'm happy to answer any questions that you might have about the work. And
thank you so much, Dr. Turner, for this great presentation. And I want to remind our attendees that you can use the Q&A feature to post any questions for our speaker. I know some folks have already done that. And maybe I'll start first with a more general question. Obviously, the discrete choice experiment is a really interesting approach. And in your study, you demonstrated its feasibility with people who are experiencing cognitive limitations. I'm wondering from that experience if you have ideas for next steps and how that method could be used in the future. Is there a role that AI could play in this, or do you see things that can be done differently so that populations that have been traditionally excluded from these types of research studies could be given an opportunity to participate?
well, thanks. Yeah, at this point, to administer the DCE, and we have thought about this, it requires a lot of interviewer time. It's very labor intensive and expanding it to a broader population would be really difficult outside a research setting. So what we have talked about, what could we use AI or conversational agents to actually help administer the DCE. We do feel that there needs it helps to have an auditory and visual aspect versus just handing people, or often people are just sent for DCEs, they're sent a print survey and then they fill it out and complete it. I don't think that would be appropriate to this population. There has to be a way of really explaining what we're doing, and sort of, and it may be possible with conversational agents to have some of that done more through AI. Although we haven't yet, so that would be a next step. It really developing a way to expand it, and that it's not quite as labor intensive as what we're doing at this point. Great question.
So one of our questions in the Q&A box, could you give us a little bit more information about the difference between home care A and home care B as the two options in your experiment?
So they differ. Option A, for each question, option A and option B change. So the point of the DCE is that, so sometimes the severity of the disease might be mild. You might have a choice of 3 hours of supportive care and many changes to support your safety. So the point is that those, I can't really say more about the difference between option A and B, because with each question, those options change. And yeah, sorry if that wasn't clear in the in my discussion, but and that's how we actually tease out. Some of the options that honestly don't make a lot of sense if you try and tell yourself a story about them, but we encourage people to answer it anyway, because that helps us determine what they're finding most important.
Another question has to do with the opinion of medical providers. Was that taken into consideration, or did that play a role in your study?
Yes, it is. In our initial interviews, we interviewed providers, physicians, geriatricians, as well as nurse practitioners and social workers, people that work with people with dementia. And so yes, and we continue to have on our advisory board individuals that work with people with dementia or memory loss. And so yeah, we consider them users as well, and we have sought their input throughout the process.
Great. There is a question about administering DCE and whether that requires training.
That's a good question. Well, I can say no one on our research team, well, that's not true. I had administered a DCE, but I'm not administering this one. Even if you had training in DCEs, I think this would have required special training, because it is so, we work so much with the people with memory loss on explaining how the process works. So, and our team has worked hard to do that. When we bring, for instance, we just brought on 2 Spanish-speaking individuals to administer the DCE in Spanish. And it has taken some training. What we do is we have them practice the DCE. You know, we have them work with one of the members of our team to go over it and practice giving it. So I think, again, I think that might be our next steps, is how to make training and giving the DCE more efficient and less labor intensive. But at this time, it takes a fair amount of training, not formalized training, but just practice doing it.
Another question we got is about the big challenge with qualitative analysis being coding, which is extensive and subjective. Do you think text mining could be used to address this challenge?
Yes. I'm a qualitative researcher, so I really believe in the strength of doing qualitative research. In many ways, I guess the heat maps what sort of a more quantitative way of looking at the frequency of codes. We have worked with. We initially worked with Trevor Cohen, who is at the University of Washington and does a lot of natural language processing, to see if we could use NLP to kind of tease out differences in discussion. He was actually mostly interested in looking at if there were linguistic differences between the people with memory loss versus caregivers that he could characterize. Because we had, in terms of persons with dementia and caregivers, we had 25 people. The transcripts were not enormous, and generally for machine learning, you want a lot of text in order to look at those differences. So we weren't able to really use those tools with the small number of interviews or transcripts. I mean, they're not small for qualitative work, but in terms of using them for machine translation and looking at trends, or not machine translation, but machine learning. I think it's a really interesting idea, and as more people as we have more data to work with, I think it's definitely worth looking at.
Our next question, the attendee thanks you for a wonderful presentation and wants to know, were there any challenges with completing the DCE with caregivers versus patients?
Yeah, we don't, just as an aside, we don't really refer to these individuals as patients because they're not under clinical care, but they're, and I don't know, we can't have input really, but Jean might be on, the members of my team that are actually watching would be better to describe that. But it has been, could you say the question again?
Yes, the question was if there were any challenges or let me pull it up again. Were there any challenges with completing the DCE with caregivers versus with patients?
We have had much less difficulty completing the DCE with caregivers. Occasionally, because these individuals are often couples, they're both elderly, occasionally that we have a caregiver that also is experiencing memory loss, although hasn't necessarily been formally evaluated for that memory loss. But to my knowledge, and we meet weekly to kind of go over issues, to my knowledge, we haven't had caregivers that were unable to complete the DCE. We have had several persons with dementia where if their dementia is more severe, or again, there have been people that really did have an emotional response to being asked about their transitions in care, and we've decided not to complete the DCE. There's a fair amount, we're anticipating that there will likely, as people's disease worsens in the 6 months and 12 months, that there may be people that are not able to complete the DCE at 12 months. But so far, the numbers have been small in terms of people not being able to fill out. what we do is if someone's having difficulty, we'll often, if it's, there's good days and bad days for people with dementia, we will reschedule if it seems like maybe things would be better at another date.
How do you deal with interaction between weight and preference? Some weighted safety as more important, but prefer the family setting, which might not be the most safe place.
Say that again, could you?
Sure. How do you deal with interaction between weight and preference? Some weighted safety as more important, but prefer the family setting, which might not be the most safe place.
Yeah, that's a great question, and we will be able to see is how what attributes people prefer, like what in making a decision, what attribute was most important to them, and not whether that means they would choose that in the long run, because there are more factors than what we're testing for that go into a decision. And ultimately, sometimes it's external factors that make the decision. But the design of the DCE really is to look at how people weigh in the tensions in those decisions making, because there is an option the option C to go to assisted living. Again, most people, I'm not being very articulate, sorry. There are many times with the person with dementia, they have not in the past in our interviews talked about safety or taken safety into consideration. And obviously, even if their preference is to be on their own, if it's not safe, the decision will often be to have a safer position, even if that means a loss of independence. And again, we're not saying that the person with dementia gets to make that decision. In fact, I think our research is kind of underscoring many of the reasons why that person shouldn't be the sole decision maker. But at least what is important to them can be taken into consideration, and it opens up the discussion, which is a difficult discussion and often doesn't take place because of the difficulty. So again, these are complex tensions. You bring up that there are competing issues, and we're not saying we're going to come up with a correct answer, but we want to hear from the persons with dementia so we better understand where they are in terms of the process.
Great. We have a question about how you initiate the DCE survey with persons with dementia and their caregivers. Was it at primary care visits, in home visits, memory care facilities? How many times did you have to visit, and how many times are best to ask them to fill in a DCE survey?
So these are almost entirely being done on Zoom, and primarily in people's, our staff is at work, or sometimes they're working from home, and they're Zooming with someone generally in their home. That we will go to. Originally, we were going to do these all in person, but with COVID, we moved to Zoom, and we have conducted a sort of a handful of the DCEs in people's home. What we're doing is we're taking a print copy of the DCE and going through it in people's homes, but most of this is taking place in their home over Zoom. And in terms of recruitment, we've received lists of individuals from the ADRC, and we kind of systematically go down the list and mostly through calling and email, ask people if they want to participate. We also have a website where people can, and I showed a slide regarding that, where people can let us know that they're interested and find out more about the study. So that's how we get most of our community members. Did that answer the question? Seems like
yes. We get a lot of questions. I'm hoping we can get to some more before the end of the hour. Can you talk a little bit more about how you narrowed down your list of potential attributes to the ones you ended up including in your final choice task?
Yeah, a couple of them were just like the degree of memory and function. Those all participants thought that was important to the decision making. So that one was sort of that one we knew we were going to have. One that we went back and forth with was because persons with dementia really talked a lot about autonomy and independence. Initially, we did have that as one of the factors. The trouble was when we did our think alouds, people didn't take that into consideration. It was almost too abstract. It was also really difficult to find an icon that represented that concept. So the DCE seems to work. We thought, I think experience has shown, and this was our finding too, that if you can, it works better with concrete attributes. So we changed the independence to safety, which again had been very important to caregivers and staff. And was also a concept that persons with dementia, even though they didn't talk a lot about it in the interviews, they understood the concept in a way that it could be weighed. And the third one, the numbers of paid in-home care, that really represented sort of caregiver burden as well as financial, and both those factors seem to be important through our interviews. So it was iterative. We would come up with our top attributes that we thought were important, and then we look at them in the actual DCE, and did they make sense in a DCE, and were those concepts were they concepts that would be weighed by people when they did the DCE. It took us over a year. There was a lot of discussion about the attributes. And it seems like we've selected ones that people, so far, we don't have the results yet, but we are getting good and consistent signals. So we know people are able to make the choices.
Thank you so much for this really great presentation. It stimulated a lot of discussion. I know we're running out of time, so if folks didn't get their questions answered, please feel free to reach out to Dr. Turner directly. And also, we will have her contact information once we upload this video on our YouTube channel in a couple of days as well. I want to thank you again. Thank you all for attending. Our next regular scheduled webinar is for May 2nd, where we have Dr. Sophie Scott from the University College London. And we also have a special hybrid webinar on our campus and online for next week with the School of Medicine's Dean's Distinguished Visiting Professor, Dr. Naik, talking about large language models. So with that, thank you again, Dr. Turner, and everybody for attending, and we'll see you next month.
Bye.